All right. Good morning, good afternoon, everyone. Thank you so much for joining today. Today we are excited to share with you a webinar on substandard and falsified medicines and their impact globally. This is one part of a series of webinars on this topic. And this webinar has been organized by the ISoP, or International Society of Pharmacovigilance Medication Errors Special Interest Group. So we appreciate their support in this very important topic. Before we jump into that, I did want to just share with you a couple of housekeeping topics. My name is Rima Mehta, and I'll be chairing and moderating today's session. During the webinar, please mute your microphone and switch off your camera. You're welcome to ask any questions and make comments via chat. I'll try my best to monitor the chat and bring the questions forward when we get to the Q&A section at the end. If you have any comments or questions after the presentation, please feel free to email Antoinette. She is reachable by the email address on the screen, support@isoponline.org. The webinar is being recorded and the video will be posted on the ISoP website for members to access after today. Another important announcement to share with you is that the ISoP mid-year meeting will be done in collaboration with the Uppsala Monitoring Center. And this year we have the pleasure of having our conference in Uppsala, Sweden. The dates for the meeting are the 14th and 15th of May. So I encourage you to go to the website and check out the symposium. The portal for submitting oral presentations is now open, so I encourage you to submit your topics for consideration. And then I recognize that we have several colleagues on the phone that may not be members of ISoP. Just wanted to let you know, if you're not a member and you're interested in joining as a member, the International Society of Pharmacovigilance is a very important organization that has members globally. It's a nonprofit scientific organization, and its purpose is to foster pharmacovigilance both scientifically and educationally, and enhance the various aspects of the safe and proper use of medicines in all countries globally. The link to join is located on the slide, but you can also easily identify it just by going to isoponline.org. I think there's somebody's feedback just coming through again. If you wouldn't mind, please muting your line so that we can minimize some of the audio feedback. All right, so let's jump into things. As I mentioned, today's webinar is about substandard and falsified medicines and their impact globally. We have the pleasure of an esteemed panel of guests joining us today. First, I'd like to introduce Professor Safieddine Ahmed, who joins us as a professor at Johns Hopkins Bloomberg School of Public Health. He's a physician, demographer, and epidemiologist, and teaches advanced statistical courses and has published in, I don't know how many different journals and how many different papers, but has over 13,000 citations. So incredible contribution to the area of epidemiology and science. We've had the pleasure from Pfizer, where I currently work, in partnering with Professor on a special program related to counterfeit and falsified medications, in trying to better understand globally the impact of counterfeit medications and looking for opportunities to target healthcare provider education. Next, we have, and I'm just checking to see if Rotunde was able to join.
I'll be replacing Rotundo.
Okay, perfect. So Pernette, if you wouldn't mind just sharing a brief background, since I didn't have that.
So I work for the World Health Organization in Geneva, where about 10 years ago, we set up the global surveillance and monitoring system on substandard and falsified medical products.
Thank you, Pernette. And next we have Kerry Mannion, who is the Senior Liaison Officer at the U.S. Food and Drug Administration. He works within the Office of Criminal Investigations and leads OCI strategic response to the global distribution of illicit pharmaceuticals and other FDA-regulated products by transnational criminal groups, which often involves collaboration with representatives from law enforcement, other regulatory bodies, intellectual property agencies, other multinational organizations, including WHO and Mark, as you'll hear later. And he's previously served as a special agent in charge of OCI headquarters in the Office of Internal Affairs. And last but not least, we have Mark Barjay. He's an inspector of drugs with the Uganda National Drug Authority. He operates an imports and exports and unit in the Directorate of Inspectorate and Enforcement. He's worked at all the designated points of entry in Uganda, quite impressive, and has had experience in understanding the nexus between product regulation and international trade. His unit is charged with import-export control of drugs, medical devices, raw materials, and he's also built within his area capacity in inspections, audits, investigations, process engineering, system strengthening, technical writing, just a multitude of experience that I'm very excited to hear more about as it relates to what's happening in Uganda and counterfeit medications. So before I turn it over to our panel members, I did want to just share with you our learning objectives for the session, which are to discuss the significance and landscape of counterfeit and falsified medications, describe the economic, socioeconomic, and pervasive health threats to the global population from counterfeit products, and then talk a little bit about some of the current interventions that each of these panel members are implementing as regulators, as policymakers, et cetera, to combat this issue. Just to frame some of the conversation, I wanted to share some statistics that I thought were very eye-opening, namely that counterfeit drugs globally are actually worth as much as $431 billion a year, and so it's no wonder why it's so pervasive throughout the globe. It's because of how much revenue it generates. But because of that, there's over 1 million people that are subject to a potential fatal outcome from taking fake or substandard medications. That's a staggering number, and this is represented by at least 153 countries around the world, including the U.S., where I'm based, to have confirmed counterfeit medications. We know that counterfeit drugs account for roughly 10% of medical products. That's quite a large percentage of the supply chain, given how much rigor and energy we put into controlling the supply chain. And then we have over 4,000 arrests for pharmaceutical crime in 2022, and that number continues to grow. In Sub-Saharan Africa, there's an article that was published that talked about 500,000 people that were killed by fake medications. So when I mentioned over 1 million people dying, 500,000 killed just in Sub-Saharan Africa. That's staggering to me. Just some other quick facts about counterfeit medications, and then I'll turn it over to our panel members. But I mentioned pharmaceutical crimes. The pace at which pharmaceutical crimes is increasing is exponential. We see that in 2002, a little over 20 years ago, we were only at about 6,000 incidents, and now we're, we were at about 200 incidents, and now we're in 2022 nearing 7,000 incidents. So that is an enormous growth in how many incidents we're seeing. We're seeing in the U.S. that 97% of online pharmacies are actually out of compliance with pharmacy laws and practice standards. And then within the U.S. again, we've had counterfeit medications seized by law enforcement agencies in every state. So there is no state in which counterfeit medications is currently not present. So those are just the couple of slides I wanted to share with everybody before I turn it over. The first part of the webinar, we're going to have Pernette share with us from the WHO perspective on some of the current global and regional trends and what WHO has in place to support the detection and engagement around counterfeit medications. So Pernette, if you have slides that you'd like to share, please feel free to share, and the mic is yours.
Thank you very much. So I'll try and share the slides. Please give me a sec. Without, right, let's share. So you can probably see my screen now. And no, this is not right. I apologize. Stop sharing, and let's do it again. Can you see my slides?
Yes, we can. Thank you, Pernette.
Brilliant. Thank you so much. So I've only got a few slides because I don't have a lot of time. I don't think I need to spend a lot of time on explaining to the audience why substandard and falsified medical products are a global threat that everyone should be aware of, regardless of the market country's income level or regulatory background, maturity level. Substandard and falsified medical products are everywhere, and they cause a very wide range of socioeconomic and public health impacts, which range, of course, from economic loss in terms of money that's spent and wasted on purchasing products that do not work. But if the products don't work, that means that there is higher disease prevalence, that there's increased mortality and morbidity. And this certainly contributes to antimicrobial resistance. And then you have the whole range of, lost productivity, lost income, increased poverty and lack of social mobility. In 2017, WHO commissioned a meta-analysis, a literature review of the quality surveys, so the surveys on the quality of medical products that had been done in the past 10 years. And there was an observed failure rate of 10.5% in low and middle income countries. So 10.5% of medicines in those countries. Sorry, there's a bit of are you hearing me okay? There's quite a bit of background on my side. Yeah?
Yes, Pernette, we can hear you. Just as a reminder to the participants to please go on mute so that we don't hear some of that feedback. Thank you.
So if you multiply 10.5% by the estimate pharmaceutical import level market in low and middle income countries, this corresponds to $30.5 billion that is spent every year buying medicines that are not of the right quality. And this is only at importation level. So it would be much more, it would be a bigger figure if we looked at patient level. And there were also two impact models that were conducted by universities, only for sub-Saharan Africa, only for children under 5, and for pneumonia and malaria. And we found that 286,000 incremental deaths were caused by substandard and falsified medical products which didn't work. That corresponds to approximately 1 child every 2 minutes. So I've been speaking for a bit over than 2 minutes, and I will speak for 10 minutes, so you can imagine the impact. And this was back in 2017, and it's only for 2 diseases in a very specific population. However, before I go further, it's important that I explain to you well what are how WHO defines substandard and falsified medical products. This was the result of 10 years of negotiations between WHO member states. So an unregistered medical product is one that has not undergone evaluation or approval by the national regulatory authority for the market in which it is distributed or used. Exceptions such as compassionate use or emergency importations would not apply, but an unregistered medicine is basically one that's just not authorized. It doesn't necessarily mean it's of bad quality. A substandard one is basically an out of specification product. So substandard, out of specification, it's the same thing. And these are authorized medical products that fail to meet their quality standards or their specifications. So this may be due to an unintentional manufacturing error. It may be due to a product that has degraded once it's left the factory or something else. And finally, a falsified medical product is one that deliberately, fraudulently misrepresents its identity, composition, or source. And there is absolutely no consideration of intellectual property rights in the definition of a falsified medicine. So I like to say that WHO prefers the F word, and we don't say the C word, which is counterfeit. And counterfeit tends to be associated much more with international property, intellectual property rights aspects. And with falsified, what's important to keep in mind is the notion of deliberate intent to deceive. So what does WHO do about it? Well, WHO tackles the problem in two ways. At a technical level, we have something called the Global Surveillance and Monitoring System, which validates data. We have a database, I'll tell you a little bit more about it, and identifies local and regional needs. This data is analyzed into information, which helps to identify policy needs and technical guidance. So the analytical results serve to develop bespoke capacity building approaches, such as projects, as well as provide some discussion elements for the member state mechanism. And the member state mechanism is an intergovernmental process which provides strategic political support and guidance to policymakers. So this is all about breaching the science policy interface, and you really need a sound evidence base to guide the decisions and the development of precise technological tools. What's important also to remember is that regulatory authorities play a key role in shaping and implementing policies that ensure access to safe, quality, and efficacious medical products. So the Global Surveillance and Monitoring System basically takes the data, analyzes it, and implements it with the view to understand the scope, scale, and harm caused. And once you understand what the problem is, you can propose some appropriate solutions. The Global Surveillance and Monitoring System, the GSMS, is called a system because there are several components to it. At the heart of the GSMS is a case reporting type of database where countries, but also the private sector or NGOs or academia notify incidents of substandard and falsified medical products to us. The data is, of course, analyzed. In the short term, we'll provide them with incident management support. We'll also provide them with all sorts of analytical insights. And we manage a network of focal points. We provide them with surveillance and monitoring tools. So these are the kind of technical assistance and products that are taken, extracted from the data once it's analyzed into information. Risk communication, such as our global medical product alerts, or target market surveillance lists. We also provide quite a bit of training. And as other WHO teams, we do a lot of normative guidance. From the data, again, it's a case reporting system. That means that you can't extrapolate to global prevalence, but it gives you an idea of who's able to detect and who is able to report. At a snapshot, you can see that we have a lot of reports from the European region, the Americas region, as well as the region of Africa. And you can see that the vast majority of notifications we receive are from national health authorities. But we also get a significant amount of reports from the pharmaceutical industry. And depending on the regions, we might get more or less reports from academia or NGOs who might themselves be doing surveys. In terms of therapeutic categories, So it's on the right-hand side. You can see that anti-infectives for the systemic use are the most frequently reported category. So this includes antibiotics and vaccines. We have a large amount of antiparasitics, which are reported to us, and 99% of those are antimalarials. And we get also a lot of nervous system products, so that might be paracetamol, for example, but it can also be anesthetics. So thinking back to the impact of substandard and falsified medical products, imagine waking up on the operating table because the anesthetic hasn't been powerful enough. For the alimentary tract, we're getting a lot of diabetes products, a lot of GLP-1 RA products. We get a lot of cancer products, which are sometimes very expensive. But the key message here is that every single therapeutic category has been notified to us. An important part of what we do to provide a service to actually combat substandard and falsified medical products is we communicate about this risk. And when we communicate about the risk, it's important not just to say there's something bad going on, it's to give people guidance on what to do about it. So there are 3 types of risk communication products that we will issue. The first is a threat assessment, which is designed to help prevent the threat from materializing. So to decrease the likelihood of the risk. Then the second is a targeted market surveillance request. It's basically a watch list that is provided only to our national regulatory authority focal points. And the last is to respond. And those are global medical product alerts, which you probably have heard or received. Maybe some of you in the audience have seen some of our global medical product alerts. We've issued a series on contaminated syrup formulations, which were contaminated with diethylene glycol. So you see the words prevent, detect, respond. You saw them in the previous slide. You're seeing them again here. And those are the 3 main driving forces, because the analysis of the database, of the data, but also of a lot of the case studies has helped us understand what were the 3, not prevent, detect, respond, what were the 3 main driving forces, which are constrained access, weak technical capacity, and poor governance. And those 3 driving forces can be combated, can be addressed by these pillars of prevention, detection, and response. Sorry, I got muddled up. Under constrained access, there are 3 main components. The first is affordability, then you've got availability, and then you've got acceptability. If a product is in shortage and people are demanding a very, very specific product, which is maybe also very expensive, it might push people to procure it from unsafe sources. Under technical capacity, we're looking at the capacity to oversee and control the supply chain to make sure that bad things stay out of it, that there's no falsified that penetrates, and that things don't degrade within it so that it doesn't become substandard. And under poor governance, we look at corruption, unethical practice, but also inefficient administrative structures. So to ensure that the public, can access safe and quality medical products, we recommend this 3-pillar approach: prevention, detection, and response. Under prevention, you want to make sure that there's a demand for quality and safe products. And this demand has got to be exerted by everyone along the supply chain. So a wholesaler has got to do due diligence, but an end user or a patient should also not go and purchase from an unsafe source. I would certainly not recommend buying an injection product from WhatsApp or a Facebook group, for example. Then you have to secure the supply, making sure that the molecules are available at the right time, at the right place, for the right population. Under detection, you've got to improve detection and you've got to increase reporting. And this is something that the pharmacovigilance experts here will be very familiar with. This data comes at a great cost, and this is where a lot of our barriers come from, collecting the data and being able to act on it in a timely way. And finally, the response is about protecting public health and preventing recurrence. So all of this is to say that substandard and falsified medical products are a huge problem, that they can be addressed with reliable data and with good trust. If you don't have the 2 of those, then you'll have a hard time addressing the issue of substandard and falsified medical products. The thing is, data and trust are probably the 2 most valuable commodities in today's world. So a lot of our efforts go towards increasing the quality and quantity of the data that we can act upon, and maintaining networks, cooperation, coordination for this information to circulate and to be received from a trusted partner. So I want to leave you here with a few key messages. It's very important that political will supports sustainable technical actions. And that political will then help support sound investment strategies. We've got to convince people that strengthening regulatory capacity is a good investment, and that will help safeguard the distribution and supply of medical products. But all of this can be done only if we've got good cooperation and good coordination. So there's got to be effective multi-stakeholder coordination, and the information has got to circulate in a transparent way. It's all about breaching the science policy interface. So with that, I would like to thank you very much, and back over to the presenters. And I don't know how to stop sharing. Oh, there it is. Rima, you're muted.
Thank you, Pernette. Maybe now we could turn it over to Professor Ahmed to walk us through another lens of how falsified and substandard medications impact public health, and where we're seeing the most significant risks, and what we've done to measure some of the awareness. Professor, are you able to share your screen? Great, we can see your slide. You're on mute, Professor. We still can't hear you, Professor. I think.
Hold on.
There, now we hear you. Oh.
Can you hear me? Excellent.
Now we can.
So substandard falsified drugs are characterized by the no active ingredients, partial active ingredients, and toxic ingredients. It is obviously clear that with the no ingredients, the drug is not working. And similarly, with the partial active ingredient, also drug is not only working, but also likely to increase the drug resistance for the particularly for the antibiotics, antimalarial drugs, those type of the drugs. And toxic drugs will directly cause the death, and including the adverse health effects. And overall, all these things and also other non-health implications, as Parnett has shown, it will increase the health cost, healthcare cost, and we lose our trust in the health system. And also from the human rights perspective, the violation of the patient rights. And overall, this is a huge financial loss and burden both on the patient and also economic loss for the country and the pharmaceutical industry. And with the loss of the pharmaceutical industry, that will also impact the R&D, research and development. And overall, you can see that how that is like a chain effect from the patients to the from pharmaceutical industry to the whole country and the globally. But although it is easy to understand the implication of the substandard and falsified drugs on the health, it is very difficult to measure. You can see the challenges. We really do not have the direct measurement, and most of the measurement, as the World Health Organization has shown, primarily coming from the different type of the modeling exercise and the modeling analysis. And so one of the major challenge for tracking this type of the problems, as Parnett has also shown, the data is critically important for tracking this thing, but getting data on this particular issue is really, really challenging, which is also hindering understanding the overall impact of substandard and falsified drugs globally. So this is a major challenge, and as a pharmacovigilance, I think there is a huge implication that could be addressed through this type of the issue. And as Rima has also shown in the very first slide, you can see that how the burden of the falsified, substandard and falsified counterfeit drug has multiplied. I simply said the multiplied. You can see that it has extensively increased over the period of time. And this is also a major problem nowadays with the people's access to the e-commerce and buying drugs from the internet. Internet has really opened the floodgate, and even the developed countries like USA, European countries are no longer immune from the substandard and falsified drugs. So this is a huge challenge, and we must address this type of issue. And to do that, we also not only address the so-called the supply chain issues, but we must also the demand side from the patient, demand side from the consumer. And for that thing, we must also engage the physician. And interestingly, when we really look into the I'm trying to go to the next page, but I'm having
The first option at the
yeah, I think. So you can see that one of the major challenges that when you really look into the healthcare providers are really lack significant knowledge on this particular issue. Particularly some healthcare providers in the USA and other developed countries really feel like that we're fully protected because our regulation system, our uh, so-called the pharmacovigilance system is very strict, so we are unlikely to have that type of the problem. And as a result, knowledge among the physicians are also very low, and they also really don't know how to communicate with the patient. We have conducted a survey in the USA and South Africa during the November 2023 to January 2024, a little over 400 sample size, and we really find that almost like you can see the 1/3 of the healthcare providers indicate that they really do not know the problem of the extent of this type of the substandard and falsified medicine. And also, almost like universally, you can see that almost like 84% of the healthcare providers indicate that they do not know what is the interventions to prevent the substandard and falsified medicine. And also, interestingly, many of these physicians, almost like also over 80% of the physicians suggested that they do not know how to report, when to report, and where to report. And this is a major challenge you really find. And another challenge really from the patient perspective, they feel like that majority of the patients, almost like a 90% of the patient, consider the cost are too high, particularly as you can see, even the cancer drugs and nowadays are subjected to the counterfeit, and that's really is a major problem. And cost is an issue, and that's the reason they often go to the outside or often really rely on the e-commerce sources, internet, unauthorized internet sources. So those are the major challenges we find, and we really consider that both the demand and supply should be work together to prevent the challenges of the substandard and falsified medicine. Thank you.
Thank you, Professor. Now let's shift gears a little bit and talk about some of the current interventions that are happening in the different spaces of our panel members. So, Pernette, can we invite you back to share with us some of the efforts that WHO is doing to address the risk of falsified medications? I know you've touched upon some of them in your prior slides, but if you have some more areas that you wanted to touch upon.
Yes, of course. So we work a lot with countries to build their regulatory capacity, because the market control function is one of the core regulatory functions. And it's important, of course, to have good inspectors for quality assurance, but also for quality control. You know, it's kind of, the supply chain may sometimes be divided as what's before market manufacturer release and what's after, once it leaves the factory doors. We also work basically under prevent, detect, and respond, those 3 pillars. We've got 12 different functions, and we provide support for each of those 12 functions. So we're, for example, working on a risk communication and community awareness toolkit, we're also working on a toolkit for trainers to be able themselves to develop training on substandard and falsified medical products, so that more pharmacy students and biomedical life science students can be made aware of the issue. We are working also with many other stakeholders in this area, for example, the UN Office on Drugs and Crime, to help law enforcement, but we're also working with partners such as the US FDA, and I'm sure Carrie will talk about it, to train all sorts of stakeholders in these different areas. And Professor Hamid mentioned it. There's the supply chain, which I would say is classical, but there's also the internet supply chain, which needs to be addressed. So on the three areas of prevention, detection, and response, we do quite a bit of work, whether it's from awareness raising or from quite innovative detection technologies and reporting tools to helping partners respond. Am I the only one who can't hear, Rima?
Hi, sorry about that. I was on mute. Thank you, Pernette, for sharing some of those impressive efforts that WHO is doing, and quite a large lift, especially on a global scale. Maybe we could now invite Carrie to share with us some of the strategies that the FDA is employing to address the risk of falsified medications, and where there may have been partnerships with other regulatory bodies or markets to address the issue. Thank you, Carrie.
Oh, thank you, Rima. And appreciate the opportunity to be here this morning, at least in the U.S., with so many friends and colleagues, not just on the panel, but also calling in today. I can see many familiar names and organizations, so thank you for taking the time to join. As my colleagues have said throughout, it literally is going to take each of us working together to make a difference regarding a problem that affects all of us, right? And some of that will be informal partnerships, some of that will be informal, but essentially we need to leverage cross-cutting expertise and authorities to really make a difference as it relates to combating the shared threat of falsified and substandard medicines. Just really quickly, as Rima mentioned, my name is Carrie Mannion. I work for the US FDA's Office of Criminal Investigations. That is a unique capacity that the FDA has. So we're fully empowered law enforcement officers. We testify in court, we make arrests, and really kind of through our work, we work across the globe to hold bad actors accountable and disrupt illicit supply chains. Quick disclaimer, and it's good here, it's on the slide. These are my own personal views. They don't represent that of the entire FDA. Moreover, some of you on the call today may have differing views or different expertise and opinions you want to share. I would invite you to reach out to me. Let's have a dialogue. I want to continue to learn. There's a lot of strategies and a lot of really talented people and value-added initiatives out there that we're not going to touch upon today that we would benefit from learning more about. So please do reach out. I'll start really quickly talking about some of the enforcement challenges that Pernette and the professor mentioned already, and Rima. Really what we're talking about here today transcends borders, right? You look at these illicit supply chains. My own cases, we've had products come from literally all over the world. They'll go to the pharmacist, they'll go to the wholesaler. Really what kind of changed my approach, and I would offer a lot of what we do within the Office of Criminal Investigations, was the counterfeit Avastin case in the early around 2012. And really what that led to was the recognition that bad actors weren't just selling illicit products, including substandard and falsified products, to consumers directly. They were reaching inside of regulated supply chains, i.e. marketing these products to doctors who in turn were passing them on to unsuspecting consumers. This led to a series of 5 cases and evidence that showed literally thousands of doctors have been impacted by these bad actors. Now, these supply chains went far afield. As far as Pakistan, Turkey, involved very complex maneuvers to avoid detection by regulatory enforcers. and customs officers, such as transshipment through free trade zones, stockpiling products in warehouses all over the world. It was eye-opening. Really quickly, and everyone's talked about this as well, is the critical importance of sharing information. Bad actors, believe it or not, share information. They have groups amongst themselves. However, the reality on the government side is we're often bound, and rightly so, by legal requirements and customs treaties and information sharing agreements. And oftentimes those are within particular sectors. And bad actors actually exploit that to their benefit. They recognize that it's usually regulators that talk to regulators and customs officers that talk to customs officers and police that talk to police. Wherever they're able to move freely like water, right? They find the gaps and the weaknesses. The global supply chain really often involves the misuse of things that were intended to make our lives easier, like the internet or the mail stream. Like, there's no one that came up with the World Wide Web that thought that, hey, this would be the primary vehicle to advertise and potentially distribute illicit products, regardless of the commodity, all over the world. This was supposed to make our life better, and it has in many ways, but it's also brought with it a series of challenges, right? Like, how do we identify where the bad actors are located? You know, where are these transactions occurring? Where are these websites housed, etc. Very smart too. They don't operate just on the surface web. They're adapted selling their products in the dark web as well. They're using encrypted apps, just really making it difficult to understand where these products are coming from, where they're going to go, and of course, who is selling them. I think, and this will be a point we're going to talk about in more detail when my colleague from the Uganda National Drug Authority speaks after me, is it really takes a coordinated effort by multiple agencies, international organizations, countries, and regulated industry to be effective. At least with an FDA, we call this now a whole of societies approach, and that's kind of almost an evolution in thinking. It used to be a whole of governments approach. You know, one government could not do it by themselves. It would take a series of governments. But the reality is, one government or even a series of governments is not going to be effective on its own in the big picture. It's literally going to take everyone. So here we are. Here we have this whole of society approach. This started based on the Aston case and the cases that followed. We've initiated 4 of these cross-cutting initiatives since 2017. The first one was with the UK, essentially looking at the misuse of a trade regime. Again, it's something that was intended to support legitimate commerce that was being abused by bad actors, where goods were being brought in from all over the world. The UK was part of the European Union at the time, and then essentially transshipped through the EU as a means to avoid detection for onward shipment to the US. It was eye-opening. I mean, we're literally talking about tons and tons of medicines a year. And I give credit to our colleagues from the government of the UK. They essentially agreed to take on additional work to look at a problem that, yes, it did affect them, but it didn't affect them as much as it did for their colleagues in the US. I mean, they essentially said, well, look, we'll support an initiative that's actually ongoing now that will look at goods in transit, and these goods in transit aren't going to stop in our country. And that's a point I want to make sure I emphasize. One issue we collectively face is most of our response is at the importation level. So goods literally move from all over the world, they're transshipped, right? But very little scrutiny generally is given to exported and transshipped products, which means effectively each of our countries acts almost like the goalie, right? Our neighbors, the people within our region, the people that we trade with and share information with are moving goods all over the world, not knowing they're illegal, right? But because we're not giving close scrutiny to exports and transshipped products often, right? We're essentially each of us acting as the goalie for our own national borders, which in turn creates a series of enforcement challenges. It's often very hard to monetize one seizure or a series of seizures and conduct an enforcement regulatory action or a criminal enforcement action, you know, on the far corner of the world somewhere else. The second one we did was with the government of India, which I'm very proud of. We did the first bilateral enforcement operation with our Indian colleagues, looking at medicines coming from India being transshipped kind of all over the world and then ending up in the US. It was eye-opening. That work continues. We also have a really robust relationship with the government of Pakistan. In the midst of COVID, right, when everyone's disrupted and, you know, what can we do? How can we continue to build bridges? We, as part of a coalition of US agencies and other international agencies, did an online virtual program with them where they're teaching us, we're learning from them. And I think that's an important thing to remember too. nobody has the solution. And all these initiatives, it's everyone essentially learning together. What works for you? What are your priorities? What are your processes? And what are your regulatory and law enforcement or legal parameters? And of course, I'll talk about, Mark will talk about Operation African Star next. And I do want to point out that involved the governments of Uganda and Kenya. And I know Mark is speaking on behalf of kind of the Operation African Star team, but I did want to take a moment to recognize that our colleagues from the Kenyan Pharmacy and Poisons Board are also on the call with us today, and they were obviously instrumental in making Operation African Star a success. So thank you, Rima. Turn it back to you.
Thank you, Carrie. Really, really eye-opening in terms of where the gaps are and where more efforts needed. And I'll be interested to hear towards the end maybe what FDA is looking to do to close some of those gaps or create stronger partnerships. So hold that thought. Over to you, Mark, since Carrie gave you the nice segue into your presentation. Really excited to hear now what African Star has been working on to address the issue of falsified and substandard medications. You're on mute on the screen, Mark, just so when you get started.
Thank you. Thank you, Rima. And good evening, everyone. Just like the current speakers have elaborated, Professor Ahmed, Panet, and Kerry, we all face the same issues, same challenges, and are all working to have them resolved. My name is Barja Mark, an inspector of drugs with the National Drug Authority of Uganda. And I'm here to share our experiences first as a country, but also under the auspices of the African Star. Uganda is a small country in East Africa, landmass of about 241,000 square kilometers and growing at a fast rate. The body mandated to regulate health products in Uganda is National Drug Authority of Uganda. And we have various accreditations, ISO, we have a WHO pre-qualified laboratory, with Center of Excellence, and are enforcing and carrying out various activities we have adopted and adapted from WHO norms and standards, and all our activities tie into the prevention, detection, and the response of substandard and falsified products being moved through international trade. So in my slide here, I just highlighted some activities we do. Some at the before the prevention, such as the control of clinical trials, product assessments, the GMP inspections, but also we carry out market surveillance, import-export control, as a way of detecting any ingress of some of these products into our supply chain. This slide shows the life cycle of our activities, and as mentioned earlier, it highlights where we are doing the detection and where we are doing prevention and then the response. Early last year, we had the opportunity to engage with a team from the UPU, Universal Postal Union, and the USFDA, the INCB, at a conference hosted by the Communications Commission, where as a country, we were privileged to be invited to participate in a one-of-a-kind initiative on the continent called the African Star. And this drew technical expertise and capacities from both in-country specialists. For the case of Uganda and Kenya, we had expertise from the police, anti-narcotics, the communications commissions, the tax authorities, the regulator, the aviation specialists, among others. And on the international stage, We had support from the US FDA, European Commission, USAID, Diplomatic Security, the Pharmaceutical Securities Institute, among others. And through these collaborations, we've made numerous observations that as a country, we have known and are working to combat, but what's happening that other countries are going through the same issues, and we can share information, share resources to combat this. So some of the observations were that we had 92 seizures of unique pharmaceuticals, and some of these medicines are mostly being shipped through porous borders, through the courier services, the mail services. And with support from some of our partners, we were able to take advantage of a system called the Ionics by the INCB that was used to record this data, have it analyzed and turned into actionable intelligence for action. Like I said earlier, through these activities, we believe that we need to collaborate more as personnel in the health sector. And also we need to have synergies, deliberate synergies, to engage all stakeholders to take advantage of their expertise and their competencies to counter this problem. The African Star was a successful initiative, and we are in the early phase of preparing for the next iteration. And we are happy to partner with National Association of Boards of Pharmacy in the US on what is being called the Pharmaceutical Traceability Pilot Program, where we intend to use GS1 technologies to track and trace products moving through international trades, looking out for those that may be diverted from the trade markets, and those that may be either substandard and falsified. Thank you.
Thank you, Mark. Really interesting to see how the work in Uganda is really connecting the rest of sub-Saharan Africa together in trying to create a more concerted effort. So thank you for sharing that with us. So as I mentioned, I did want to keep the last segment to have more of a conversation with each of our panel members and hearing more about how they're approaching next steps with counterfeit medications in particular. I think we've heard from each of the perspectives some common themes, one being, no one entity is going to be able to combat this issue alone. It really does need a group effort, as I tell my kids sometimes, is things just need a group effort. And I think the nice thing about who we have listening into our conversation today is that we have representation from so many different industries and bodies that are not only interested in this topic, but probably also have active activities going on to try to move the needle on this issue. And on our panel alone, we have, as we've already talked about, representation from academia, pharmaceutical industry, and regulators. So maybe I could start with back to you, Pernette, and hear some of your reflections or thoughts on, when you take a step back and you look at some of the trends that we're seeing, Carrie mentioned, and Professor mentioned how there's been this churn around things that had good intentions, but ended up as a pathway for bad intentions, like the internet and things like that. When the WHO takes a step back and looks at the landscape, what are some of the future challenges and emerging trends that you're seeing from your vantage point?
Thank you, Rima. So that's I'll try and have a short answer to that complicated question. But maybe before I answer, we're all saying, oh, it's really important to coordinate, it's really important to collaborate, and multi-stakeholder collaboration, blah, 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 blah. And someone who's maybe not so involved in the topic might say, well, they're soon going to tell us that water makes you wet, you know, or something so obvious. But actually, collaboration coordination is not that easy. You know, at the end of the day, it's human beings. We all have a huge amount of work. It's difficult to get through our to-do list. And we've got to, sometimes you got to stop working and you got to start thinking. And you got to start thinking about who might be in a better position than you, your team, to do a particular piece of work. And strategic stakeholder mapping is not easy to do. And so I just want to highlight that. It's not, we all say, oh, it's so, you know, we've got to collaborate, coordinate, and from the outside might seem obvious, but you know, I can see Kerry laughing, but that's the reason why Kerry's job exists. He's a liaison officer. And even in today's world where you do have the internet, which has been created indeed to accelerate and simplify information sharing, well, sometimes we're you know, drowning under the amount of information that's available. So that's one thing that I wanted to highlight. So in terms of things that were originally intended to be good and then turn out bad, it's complicated. But access to safe and quality medicines is a fascinating topic because you can have all sorts of perverse incentives. So to have access to quality and safe and efficacious medicines and affordable, you've got to make sure that the right molecules are available in the right dosage and the right conditioning to the right people at the right time. Several years ago, the Global Fund initiated a private-public partnership through which they subsidized the purchase of certain antimalarial products, which were artemether-lumefantrine combinations, by the private sector, because they wanted to breach the fact that these antimalarial products were not sufficiently available and that they were going to leverage the distribution networks of the private sector to make those products more widely available. And to do so, they would subsidize them so that they would make them more affordable. And to make these acceptable, which is the third component of access, they designed something which is called the green leaf logo. So some of you might be familiar with that or not. The thing with the green leaf logo is that people who falsify medical products recognize this as a mark of quality. It can be the green leaf logo, like it can be a WHO logo, like it can be the logo of a private company. It was associated to a guarantee, an assurance that the product was of good quality. And what we found out is that a lot of the products which were falsified actually bore this logo. So it's a bit ironic that a logo that was developed as a mark, an assurance of quality, was also what was targeted by the falsifiers. But those are things which are difficult to predict. We live in a globalized world. The other thing what's so fascinating about substandard and falsified medical products is, even if they save lives, medicines, they are commodities like any others. And so they are subject to all the market dynamic forces that exist. And that's something that's quite interesting. You look at what's going on at the moment with the GLP-1 receptor agonist products, how this is another example of maybe unexpected consequences of trying to increase access. Semaglutide is a molecule that's existed for a couple of years. It's not a few years. It's not quite brand new. The moment the US FDA approved that to also treat weight loss, I'm talking about the molecule, more people started talking about it because people see that the same molecule is used in different medicines. And that increased the profile of this product, like it increased the profile of other similar products. And if you have greater awareness of something, you're also creating increased demand. And increased demand means that there's increased pressure on the supply. And with medical products, it's very important to distinguish, and that's, again, the fascinating thing about public health in general. You have to distinguish between need and demand. You might have a medical need for something that is not supported by the financial means to obtain it. And you might have a demand for something that is supported by financial power to purchase, but is not supported by a medical rationale. So you can see here we're touching on all the cases of rational use, affordability, acceptability, and all of this is quite complex, but that's what makes it interesting. And I think, that, again, the pharmacovigilance audience knows this very, very well in the way that maybe adverse reactions, there's a huge cultural dimension to the way symptoms are expressed, are felt, and then transcribed by others. So I don't know if that answers your question directly, but...
No, Pernette, thank you. I think a lot of great insights there that that I think are things to give us pause on, how we try to approach these challenges moving forward. As you said, it's simple to say, let's work together, but with the devil's in the details and how you go about
I need to spend time going onto this webinar, connecting with you, all that. Through the Johns Hopkins partnership, we've had our symposia where we've invited different representatives from various academia, regulatory bodies, et cetera, and that's been a common theme as well. Is we all have these great ideas, but how we come together and get a more coordinated effort is really the challenge in being able to do that. So thank you for touching upon that and all of the other, I think, future considerations that we have to keep top of mind as we think about this. Maybe, Carrie, I could ask you to comment on maybe some of the, anything that Pernette raised, but also curious from your perspective, since you did touch upon the collaboration with African Star and other markets. Are there future collaborations that are top priorities that the agency is thinking about and can be fostered or additional partnerships that we should be thinking about or aware of as the FDA moves forward with them? Anything you can share in that space?
Oh, thank you. Yeah, so Rima, you and Pernette are 100% right. This cooperation, it should be easy. We've known that from our earliest days in school or even within our own families, right? It takes us working together, but it just doesn't usually happen that way. And, I would offer, and I'm open to differing opinions. Oftentimes, the best successes we've been able to realize have been informal partnerships where we didn't spend 5 years trying to draft an MOU or some sort of long-range plan. It's converging around an immediate problem, finding people that are willing to work together, identifying wins so everyone can have some level of success, and then coming forward with a plan of action. I think for us too, it's also recognizing not only is there not one problem, there isn't one solution to the problem, right? And so sometimes that is strengthening regulatory capacity. Things that I'm working on related to African Star is updating websites, which is really cool, right? So we're taking operational findings from an operation in East Africa, and we literally changed the country pages on U.S. websites from people, from the U.S. wishing to travel to Uganda and Kenya and advising them what the legal and regulatory requirements are. We've had discussions regarding radio ads, and Mark mentioned it. It's also it's this challenge of information sharing. So I give the International Narcotics Control Board a lot of credit with the Onyx platform. They literally went in and re-engineered it so we could use it for this sub-regional initiative. So I'd like to stress those points. In terms of other initiatives, sure, Rima, there's none that we've disclosed publicly, but we're always looking to form kind of these coalitions focused on improving global public health, and we're obviously open to ideas and suggestions. And as Mark said, we anticipate Operation African Star 2 kicking off in April of this year. So thank you.
Thank you, Carrie. And Mark, as you're listening to some of the challenges that Carrie and Pernette have talked about and where they're seeing the future trends and moving towards in their partnerships, are there any areas that you can share that either via African Star or the Uganda regulatory body, that you represent, that you want to share with the audience at this time?
Thank you, Rima. Yes, as an agency, we are working to strengthen our capacity. We're working towards commissioning our new information management system that will improve our supply chain visibility and help us weed out some of these products. But also through African Star, we have been enlightened. Just as Kerry had mentioned, we have published guidance in what is called the Aeronautical Information Publication that goes out to airlines, and they are now required to only load goods that have prior authorization from the authority. And some of these help cut out bad actors. And like everyone is saying, collaboration is hard. But once it gets started, you begin to see the benefits. And as an authority, as a country, we are happy and ready to always collaborate for the safety of the Ghanaian people and the world at large.
Thank you, Mark. And I think that's also interesting, given Carrie's comment earlier about the focus historically have been around imports and needing to think more about exports as well. So the efforts that you're doing around what individuals have to do when they're going on airplanes and things like that is interesting in terms of connecting that import-export idea and where the efforts are well spent. So thank you for sharing that, Mark. And Professor, so I think you probably have a different view on all of this, given that you don't have the constraints of the regulatory framework that each of our other panel members are working with, but have more of that maybe step back view and have had the opportunity to engage in various conversations through the symposia that has been put on by Johns Hopkins, et cetera. So as you listen to all of our panel members and as you've listened to the conversations in some of those recent symposia and your own research in this area, what are you seeing as the future trends and maybe call to action from Johns Hopkins standpoint?
Thank you, Rima. I mean, with the e-commerce and people's reliance on internet, it really become a problem even in the developed country. And we must address it, and we must be vigilant about it. And when you talk to the physicians, we really find that they simply write down the prescription, but they do not ask about the source or where from they will buy the drug. It is important that nowadays, given the context of the e-commerce and internet sources, as you have said, you have shown that the 97% of this e-commerce are essentially fake. So we must, to address those type of the things, I think it is important that we engage the physicians, we engage the consumer. And to do so, Johns Hopkins University has undertaken, with the assistance, with the funding support from the Pfizer, a program called the Check the Box, to engage the physicians to find out whether they really talk about how can we really engage the physicians and the other healthcare providers with the patient to talk about the drug sources and to find out the risk of this type of how can really prevent people's access or patients' access to those type of the drugs. So these are, I think, is critically important that not only we are become vigilant, and program like an African study is critically important to check to control the supply, and all the regulatory bodies should be in place. But at the same time, we should not also forget about importance of the demand side to prevent this type of the issues. And we must work together, collaborate together. Everybody should be on the table to address this issue jointly and in a partnership. Thank you.
Thank you, Professor. Well, I want to thank each and every one of our panel members for their time today and all of the expertise and insights around what the future landscape of the challenges around counterfeit medications look like, understanding that this is a really important public health initiative, not only for regulators, but for all stakeholders globally. One last question that I did want to pose to see if anyone had any thoughts, since many of our participants today represent different pharmacovigilance organizations. Are there any recommendations that any of you have for monitoring of counterfeit medications that you see as potential gaps in some of the institutions that exist where that type of data is being collected? If anyone has any thoughts on that, otherwise, happy to close up the webinar. Carrie, Pernette, or Mark, anything that you've seen from your engagement where you think that there could be strengthening of pharmacovigilance organizations in monitoring for counterfeit?
I think that there's a comment in the chat, which is spot on. We speak about collaboration between stakeholders, but it's also collaboration with the patients. And I think that's also something that the pharmacovigilance know very well. People can be empowered, especially as we move toward, we've talked about the internet, about a way to share information, and it's also been a way to facilitate the exchange of goods for the better in general. But it has also helped the rise of the culture of self-medication and self-prescription. And I deeply believe that people can learn all the time, and we must trust their intelligence, and we just got to make sure that the right information is there out for them as well, and they can make decisions. So thank you for the comment there, and from Nadia in the chat, and over from me.
Thank you. Anything else, anyone? Carrie?
I would just say the critical importance of reporting, right? I mean, it's a common thread in a lot of these calls is we need more data, right? Data kind of drives like where we go next, what we do next, our understanding of what the trends are. So please just let's avail ourselves of the different databases that are out there in terms of like documenting the issues that impact all of us.
Great. And Mark, anything from your side?
Yes, just like Kerry and Brent have said, we can't respond to what we don't know. And that is why we need to have information. The vigilance needs to be, people need to be vigilant to report any adverse events. Those in the establishments need to be able to report or complain when they notice any changes in the products they're stocking. And then we can have a body of knowledge which we can detect and respond to any of these incidents as and when they occur.
Thank you, Mark. Well, I know we're a bit over time, but this was a really engaging discussion, and appreciate all those that have stuck with us through the entire webinar. As I started off by saying, this is one of a series of webinars on this topic, so we hope that you'll join us again for the next webinar in this series, which will be in or around June. More details will follow as we work on planning that session. Thank you again to all our panel members. Thank you to our participants, and wish everyone a wonderful rest of your day.